So when I got into my car this morning, the you know, these European cars all tell you when you're going to get your service, and that they start chastising you more and more the further away from your service stage you get. And it made me thinking perhaps I should be dropping off my car to get service, because now it's a couple of months overdue and it's giving up on me. And as I was thinking about coming to talk to you guys and thinking about the interactions that, say, medical people and allied health people have, and then I started comparing that to what the people at the car place well, their interaction with me and my car. It's a little bit similar. And every single time I go and get my car serviced, I walk away knowing a little bit more about how a car works. Not that I necessarily want to, but I take it in simply just so I can get the stamp in the book, say it's been serviced, and I find out about how the fuel gets through the engine, the importance of having a properly tuned engine, making sure there's no holes in the muffler. And although I don't ask for it, I actually know a little bit more about how my car works every time I have an interaction with the person tuning it. I would suggest that every time a patient who has a contact with us, whether it's medical people or non-medical people or therapists or people that know a little bit more about their condition, every time they have an interaction with us, they should walk away knowing a little bit more about that. And that's really the idea of the session today, is to really share our knowledge, or in my case, give some knowledge about the condition of Parkinson's disease. Sure, you don't need to know how the petrol gets from the fuel tank to the exhaust pipe to drive your car, but it certainly helps if something goes wrong. And this talk, I'm going to, I guess, talk to you about some of the mechanics, the problems, the underlying issues with the non-Parkinson's disease Parkinsonian conditions, so that you guys have a bit more of an understanding, or enhance your understanding about the problems that are causing those symptoms, and you can add that to your therapeutic strategies, impart that knowledge to the patients and their caregivers, and hopefully make the world a better place. So, it's not Parkinson's disease. Despite fighting Parkinson's disease sign out the front, we're talking about other issues. So what could it be? And this is the sort of question that a diagnosing doctor, whether it's the GP or the neurologist or the movement disorder specialist, is thinking every time they're seeing a patient. Now, the sort of conditions that look a little bit like Parkinson's disease but aren't caused by Parkinson's disease are listed here. And we're going to talk about the top three, that is progressive supranuclear palsy and cortico-basal degeneration, which come in a family of diseases defined by what we see under the microscope, and multiple system atrophy, which sits off to one side. The other sort of conditions that can look like Parkinson's disease, and things we think about every time we see the patient, and we reserve the right to change the diagnosis halfway through the condition, is vascular Parkinsonism caused by strokes, Huntington's disease, obviously inherited straight down the family line, Wilson's disease, which is a problem with copper metabolism, which eventually wrecks the basal ganglia, the movement part of the brain, some of the rarer conditions, and inherited spinocerebellar ataxias. Now, it can be very difficult, extremely difficult, if not impossible, on the first time you see someone to make a differentiation between all of these conditions and Parkinson's disease. And there are very few tests, save for the genetic ones, that actually make a definite diagnosis. So this is why you might see patients that are being described just in broad terms as having Parkinsonism without having an absolute definite diagnosis. And over time, clinical features emerge which help us more clearly categorise patients into these groups. A diagnosis is important for patients, because without moving from Parkinsonism to PSP as a diagnosis, you can't get the PSP handbook. If you told you've got Parkinsonism and you've got multiple system atrophy, you've got no website to look up, and you don't really have an identity. The patients and their carers will walk around saying, well, the doctors don't really know what it's got. It's a little bit like Parkinson's, it's a little bit like something else, but we don't know for sure. And for that reason, I prefer to err on the side of riskiness and come out with a diagnosis relatively early on when I see a patient, telling them the reasons why I think that's the diagnosis, and say that we always keep an open mind and check the diagnosis every time I see them. Giving a diagnosis early on helps patients understand what they've got, helps contextualise it, and helps the family and the caregivers plan out things according to what's the expected prognosis and natural history. Now, if you're going to have Wilson's disease and you need to take medications every single day, then you need to know that. If you've got Huntington's disease and there's a 50% chance you're going to pass it on to children, you need to know that. If you've got PSP and you're not going to live to see the 2022 World Cup in Australia, then you need to know that as well. Hopefully in Australia. Now, many of the conditions we have don't have curative treatments, except for Wilson's disease. But there are therapeutic interventions which come from the drug cabinet and also from therapy input, and these are important to plan out according to the expected associations with the Parkinsonism that come with these different conditions we're going to talk about. And finally, diagnosis is important for research issues and quality assurance. If there's no research, we don't know what's, we won't advance our understanding of these conditions and head towards a cure. And I'll point out some of the research that's gone on and some of the interventions that are emerging from that research.
If the disease involves loss of substantia nigra, there is difficulty in correcting posture when suddenly displaced. This man literally falls backwards when he is lightly pushed.
So this is typical Parkinson's disease in 1948. We don't have typical Parkinson's disease these days because there's medications that improve many of the symptoms of Parkinson's disease. This guy had 8 years of the condition. He's got a slumped, hunched posture, resting tremor, postural instability, slow movements, and this would be expected to continue over the following decade or so, eventually leading to death probably between 15 and 25 years after onset. Now, the natural history of Parkinson's disease is completely changed by the introduction of medications, and we wouldn't normally see someone looking like that after about 7 years of disease. But it's 25 times more common than the conditions we're going to be talking about. So anytime you walk into a movement disorders specialty clinic, you're likely to see probably 20 patients with Parkinson's disease and only 1 or 2 with PSP or MSA. Briefly, Parkinson's disease, apart from the clinical features you're familiar with, patients also have a loss of sense of smell. They have sleep disorder, REM behaviour disorder during sleep. That is that they act out their dreams when they're asleep, kicking out and yelling out and sometimes falling out of bed or sleepwalking. Patients usually develop visual hallucinations later in the disease and they have a good or excellent response to the medications. Now these 4 things don't happen in the other conditions that